Hi, good afternoon, everyone. We are very pleased today to have our second Translational Science Seminar series on focus on policy. And we today are going to be hearing from Dr. Erica Phillips and Nurse Maureen Sentesy Wagner on translating COVID science into school policy insights from school health administrators. So I am Charlene Schwann, and I'm the core administrator, the core lead of the Health Policy Impact Core of the Penn State CTSI. And I'm very pleased to have Dr. Phillips and Ms. Sentesy Wagner with us today. So Erica Phillips is a public health nutritionist with over 10 years of experience working in low resource contexts in sub-Saharan Africa and the Caribbean. She has a PhD and a master's degree from Cornell University. Much of Dr. Phillips' work and research has been in the assessment and quality of care delivery of maternal and child health nutrition programs and the effect of mycotoxins on child growth. Maureen Sentesy Wagner is a registered nurse who received her BSN from MGH Institute for Health Professions in 2011. Her commitment to public health began with her work in refugee resettlement in the Boston metro area. She contributed to research and publications on adolescent refugee resilience with the University of Illinois and the Harvard School of Social Medicine, and has also worked for John Snow Inc. on tobacco cessation. She has also worked for the Boston Healthcare for the Homeless as a nurse, as well as Boston Medical Center, formerly Boston City Hospital. And most recently, she has spent the last 5 years working in schools in the State College area, including at this State College Friends School, which is the topic of our talk today. So we are I will be in charge of the slides today, and Dr. Phillips, if you can please let me know when you would like me to progress, that would be great. We have a small group today, so if people have questions, please enter them into the chat as we go along, and otherwise we will have a Q&A after the session. Thank you all very much.
Great. Thank you, Charlene. Thank you so much for inviting us to talk today. It's an honor and a pleasure to be here. Next slide. So we first wanted to introduce ourselves. In addition to what Charlene shared about us, I'm a public health nutritionist, and I've been working with the State College Friends School, or SCFS, for 3 years now. And you might be curious why a nutritionist is working with the Friends School on COVID-19 policy. My background is almost in part as much in public health as nutrition, and working overseas in mostly low-income countries in sub-Saharan Africa. I always joke that I'm used to working in a really chaotic environment, and everything about the pandemic in the first few years has been nothing but chaotic. So in some ways, working in that context has been very familiar in terms of having to make decisions with knowing that you don't have all the information you really want to have to make decisions. Maureen, do you want to introduce yourself?
Sure. I've been working with Friends School for 2 years now. When my kids started going there, that they recruited me to help out. I had been working in another school previous to that at the very start of the pandemic, and then into that first year. Working on contact tracing and mitigation planning at another school. And then last year I worked for both schools, and now I'm just with Friends School this year.
Great. Next slide, please. Okay, so a bit of background about the Friends School if you are not in the State College area or maybe have never heard of the Friends School. So the Friends School was founded in 1980. It serves a pre-K to 8th grade population. There's currently 105 students enrolled with about 30 faculty and staff. And it doesn't only serve kids in the State College area. There's kids that come in from 6 surrounding school districts. And you might have already noticed that it has the Friends in the title or in the name of the school, which means that it's a Quaker school. And so it uses Quaker pedagogy, which is very much focused on service, social action, hands-on experiential learning. About 30% of families at our school receive some financial aid. And in 2022, the school awarded over $230,000 in financial aid to friends' families. About 60% of families have some affiliation with Penn State, whether they're faculty or staff, or work somewhere with the university. And so, yeah, there's a strong Penn State connection being in the backyard of the campus here. Next slide. So first, to back up a little bit about how things evolved at the Friends School in terms of pandemic policy. Everyone has lived through this together, and we've shared so much of this together. But just to kind of remind ourselves where we've been, the first school year was a normal year until around January or February of 2020. And then we thought we were going to flatten the curve, maybe close schools for a few weeks to who even thought a few months at that point. But we were going to flatten the curve, and then schools never reopened. I don't think any school in Pennsylvania reopened that school year. But that summer, there was a real feeling amongst the teachers and the administration that going remote that year just was not something that they liked. They really wanted to be in person with children if there was a way to do it safely the second year. The second year, so that is what happened. The second year broadly was a complete patchwork of policies between state and local schools. And nationally, I don't even think, I could be wrong about this, but looking back, I don't think the CDC had very clear school guidelines for that first full pandemic year of 2020 to 2021. And we had contacted a number of schools and the school district, and everyone had different policies about spacing, about when you were allowed to come to school, which symptoms, if you had 2 of these and 1 of those, maybe you could come, and then if you had 2 of those and 1 of these, you had to stay out for a certain amount of time. So that was year 2 in summary. Year 3 was really, in our terms, really trying to follow the science to meet blank objective or objectives. And at different times throughout the year, those objectives changed for different people. And year 4, which is this year, is a big sentiment from a lot of people of, isn't the pandemic over? Why do we still have some pandemic policies? Is what a lot of people are saying. And on the other hand, there's a lot of families still saying, we really want to protect ourselves from getting COVID. We haven't had COVID yet. And there's a lot of research about the negative effects of COVID. So, so we have this big mix. Amongst all of that, in different years at the Friends School, or almost every year at the Friends School, there's been a different process for decision making about COVID policies. The first year started with, well, the very first school year, year 1, had no committee, of course, because COVID wasn't something anyone expected and was prepared for. The second year, year 2, there was a very large committee. It was kind of all hands on deck. A lot of people wanted to be involved. A lot of people wanted to be involved. This year 3, we pared it down to a smaller committee with people who had a little bit more focus on public health, epidemiology, and the school administration, and also teachers, at least one teacher representative on the committee. And this year we started with a committee and have almost at this point really disbanded a committee, and the decision making has shifted back to the school administration. So I'm going to walk through each year a little bit more in detail. If we can switch to the next slide, please. So like I said, in that first full school year, COVID year 2, to my memory, to my knowledge, there were not very specific CDC guidelines for schools. There were in general about how long people should isolate and quarantine and distance, et cetera, but not specifically for school. Like I said, there was this desire to be in person for the majority of the community. The school did accommodate a number of families and a teacher who did not want to return in person this year. And so they made their own kind of virtual academy that was a Friends School driven program. And many of those families and the teacher are still together today. They have gone through their coursework together now. One of the great things about the Friend School is its location and the space. So there is strategic use about using outdoor spaces while the weather was warm enough. And this, if you go to Google Maps and you look at Street View, this is still the image that's on Google Maps. And you can see the 5 tents spread out outside on the grounds. Each of those, thank you, Charlene. Each of those tents was a different grade. I don't think I mentioned actually in the beginning slide that classes at the Friend School are mixed grade levels. But for that first full COVID year, they were split into single grade levels. So like right now, it's a K and a 1 combined class. But in that first COVID, and actually in that first COVID year, K and 1 was combined. But second grade was separate, third grade was separate, fourth grade was separate, et cetera. So each of those tents house one of those grades. But being State College around Thanksgiving time, there had to be a transition plan to come inside. And so they did. Every classroom was taken by one single class, including what are usually shared spaces like an auditorium, as we call it, a community room, was taken up by one single class. So the spaces in the school were entirely used, and classes were podded to try to keep them separate to reduce any potential transmission. Some of the challenges of outdoor teaching were when it was rainy or windy or both. As teachers say, they kind of had to huddle in the middle of the tent because kids could get wet on the sides of the tent if there was any wind when it was raining. It could be noisy. Teachers had to wear microphones so that when kids were spread out, they could hear them. So it was really exhausting for teachers and exhausting for children as well. And it also turned out that there was a bit of a zoning challenge in trying to continue that throughout the school year. So that lasted for the first few months of the pandemic, and it felt really safe, I think, for most people who participated. Some other adaptations that were made that year were lower enrollment in general in the school, so that kids could be spaced out properly, which was at least 6 feet at that point. We developed our own specific contact tracing materials because we wanted to have as fast as a response as possible. In that first year, you might remember, there were a few things happening. First was that at times when the system was overwhelmed, when the state was overwhelmed or the county, contact tracing could take up to five days for it to even start. And then to contact all the contacts would take even more time. So we developed our own contact tracing material so that as soon as we heard there was a positive case, we could start contacting families right away and let them know. And hopefully we could reduce the amount of time kids would be out of school if that happened or when that happened. Yeah, and at that time, things just felt a little bit less controversial, maybe not so much around the country, but at least in the State College area, most people were on board for all mitigation because people weren't vaccinated yet. There was still a lot of fear about getting COVID. And so, there was very little to no pushback about masking, distancing, podding, really any mitigation efforts. Yeah. So next slide, please. And by the end of that year, even though by the end of that year, the CDC did come out with specific school guidelines, we kind of really at that point preceded them in figuring out what we needed to do. Not to say we got it all right, but we really understood that by that point we needed layered mitigation, otherwise known as the Swiss cheese model. And we wanted to layer and really fortify every single layer we could at that point, mitigation to prevent the chance of any in-school transmission. Yeah, and the Swiss cheese model really carried us into year 2 or the next full COVID year. Next slide, please. Thanks. So by the end of the year, school had been open all year long. There were 2 classrooms that had, I think one classroom missed 1 day and a second classroom missed 3 days of school because of an in-school case, and there were in one situation there were so many potential close contacts that we just decided to keep the school or keep that classroom specifically home for 3 days. But we were not aware, and we don't believe that there was any in-school transmission in that first year. Amazingly, there was no teacher turnover that first year either, but the teachers were exhausted. And by the end of the year, they were able, and they really wanted to articulate what their goals would be for the next year. Because by that point, by the end of the year, teachers were vaccinated, parents were vaccinated, and so there felt like there was a possibility for changing things around. Also, because there was the CDC guidelines at that point, we also had the opportunity to read those, analyze those, interpret them, and decide, as a small independent school, did we want to follow those exactly? Were there adaptations we want to make? And if so, which adaptations did we want to make? And so this is where, in my mind, kind of translation started. Because there were a lot of decisions and nuance to be made at that point. I think more nuance than in the previous year. So the teachers came together and stated their goals, and their goals were to protect the health and safety of all community members. Without a doubt, they wanted to conduct in-person school, and they wanted to use Quaker progressive pedagogy, which is the foundation of the school. And what that means in translation is often working together in teams and groups as a community to solve problems, working in small groups, and a lot of hands-on work. So they wanted to be able to do those things with as few restrictions as possible. Another truly wonderful thing that happened at the end of the year is that there was federal COVID emergency funding for schools. And so, which I guess there was in the previous year as well, the use of it was less, I guess, less broad than we could apply for at that time. So we were awarded the EANS grant in late summer of 2021. And that's what allowed us to invest more in hiring 2 professionals, which was Maureen and I, the health administrators. And we also were able to invest in a number of other things that I'll talk about. Using that grant money, we could also reach out to a number of professionals for more guidance. And so one of the biggest areas that we invested in using that grant was expertise in indoor air quality. So next slide, please. Kind of mentioned some of these things already. We decided some of the things we didn't really feel like we had to translate because it just seemed straightforward and there was no adaptation needed. So case management and distancing, for the most part, we followed the CDC. But there were a lot of translational questions about the use of at-home testing, which types of masks, and if we wanted to have interactions between classes, and how to handle out of class time, like whole school assemblies, after school care, etc. Someone who worked with us previously, who is no longer in the State College area, was an epidemiologist, and she was really incredibly forward thinking about the use of at-home testing, and she really pushed school to consider the various uses of at-home testing, whether they be general screening for all students and faculty, or using it just to focus on if someone is symptomatic, if they were close contact, if there were visitors in school, or so thinking about all the different uses of at-home testing. And that summer, we went back and forth trying to think about all the ways that we could use at-home testing. We were hoping, at that time, there was still a hope that at-home testing would be, the price would come down and we could use it more broadly. And that never happened. So we were thinking really optimistically about it, and we had to scale back, but we have still been using it quite a bit, focusing mostly on symptomatic people and close contacts. The types of masks, the CDC has never made a strong statement about types of masks. But at the beginning of that school year, we were strongly recommending high quality masks, KN94s or KN95s, KF94s, N95s, etc. We didn't require it at the beginning of the school year. We recommended it until there was a case of in-school transmission, and then we did make it a requirement. I will talk about the ventilation and filtration in another slide coming up. So I'm gonna just say that that was another big area that summer. We started the school year, just to give you an idea of what mitigation looked like at that time, with this kind of chart, which this was based on the CDC distinctions of transmission levels at that time, which has now changed. But it was, so we used their template, and then we had to have this art and science back and forth between us, the health administrators and public health professionals, the administration and teachers, to try and decide, for some of these things, where do we draw the thresholds? What should the policy themselves be, and where do we draw those thresholds? So the result was very much a back and forth between those groups, how teachers wanted to envision what they could do, what we felt would be most safe for reducing transmission and upholding the 3 objectives of the teachers, and the administration, the head of school, having the support of those policies. Next slide, please. So here's where one of the big pushes was in indoor air quality. So we worked with a professor from Penn State who also happens to be the head of the ASHRAE COVID-19 pandemic task force. He is wonderfully community minded and connected, and was thrilled to be able to apply his expertise in our school. So it had also just so happened that having a 30-year-old building or 40-year-old building meant that there had to be a big HVAC fix around the time of the pandemic, just before the pandemic. And so with that came a balancing report, which means that a technician went around and measured every single vent in the school and recorded what the flow rate was for every single vent in school. So Dr. Banfleth from Penn State helped us interpret that report. And with a group of parent volunteers, we went around and measured or tracked each vent in every single classroom, measured the size of every single classroom, took the flow rate from that report, and we could calculate for every single room in the building what the flow rate was that was coming in from our HVAC unit. Our HVAC unit, while it was old, it was set up not to recirculate air. So that was a big plus when we understood that. And then once we had that kind of baseline of what the HVAC would provide in terms of whatever metric is used, whether it's air exchanges per hour or flow rate per person per minute, we could use that to then try and achieve what we were hoping for, or what the target would be, to reduce the potential for transmission. So of course, buildings, I'm sure all of you probably on this call know, buildings are built to code, and code is not the same as indoor air quality for reducing transmission of infectious diseases. So some people would say, but it's built to code, so it's probably fine. But we understood, because of the respiratory nature and transmission of the virus, that no, we actually needed it to be meeting a higher level of quality. So under Bill's guidance, we purchased a number of air filtration units. There's 3 or 4 in each classroom, depending on the size and the number of students estimated to be in those classrooms. We did build a number of DIY units. On the right-hand side are those Horsey Rosenthal boxes. The one in that picture with the green tape was made by middle school students this year, and there's, in the larger areas like the community room, there's a number of those that are always on. And we monitor those in the picture in the middle on the bottom. There's a CO2 monitor amongst the toys and then the games there. And one of the things that we continue to do is to monitor the CO2, the carbon dioxide. And if ever we think it's too high based on all the calculations that we've done, then we talk about it. The most efficient thing to do then is open windows. But usually now that it's been a 2-year work in progress, they're almost always at the levels where we hope and we think that they should be. Thanks. So I've talked already a lot about the testing program, and these were a number of the questions that we needed to answer about. Should it be all students? Like, should it be used for screening, symptomatic, exposed? If it should be used to determine when people should end isolation, or visitors. And we really had to decide. There's trade-offs in all policies, so we had to think about who should use them and when, for how long, and the cost of doing so, because at that point, people were not getting 8 free tests per month through their insurance. And of course, even when we are, not everybody at school has insurance. So we did use the IND grants to procure tests. And throughout last school year, we gave out over 800 tests to people. So we were able to bear the cost through the federal grant. But again, there's, just to point out the trade-offs in trying to think about developing these policies. There was also another big question at the time, and there still is, to some extent, depending on the way the question is framed about testing. A lot of people might be reading in different news sources like rapid tests don't work. And of course, as a scientist, I'm like, well, what is your purpose? What is your question that you're trying to answer when you're trying to use rapid tests? And ours specifically for a school was, if you come to school that day, could you possibly be infectious and transmit the virus to someone else? So our policies were designed to, for people to test the morning before coming to school. And if it was negative in the morning, then there was a relatively low probability that throughout the day, their viral load would increase so much that they would become highly infectious at the end of the day. So we would test people in the morning, and we, in most cases, we asked people to serial test at least 24 hours apart. Of course, around Omicron and when tests became so much more available, there was a question about, could you be infectious before testing positive? And in part, it seems like people were testing so much earlier that had a large influence. So, a lot of times when these things would come up, we would try to tweak and adapt our policies to make sure that we were staying up on the science as much as the science could stay up on the question, because so much was changing so quickly. One other thing here is I mentioned is about the PCR validation. Again, just in some in the scientific literature, but also in the very publicly available literature, people would say, well, PCR is so much more sensitive, so it's a better test. Which is true that it's more sensitive. So if you really care, if you really want to know if you had COVID, then that might be the better test to take. But to make a decision of, should you come to school today? Could you be infectious today? A PCR test is not very helpful because there's no immediate PCR test. In the beginning of the pandemic in State College, you could not get results before 4 days. Usually it was somewhere between 4 to 10 days. So comparing PCR, the sensitivity of a PCR to a rapid test is really a false question in our mind for decision making. Another benefit about about at-home tests is that parents could do it privately, and so school didn't have to be involved. School didn't have to be involved in that decision making. Parents could take that on and do it at home. So the rapidity, the speed with which we get results with an at-home test supported their use. Okay. So COVID year 3 at school, which was last school year, was when we had our first case of in-school transmission around Thanksgiving. And like I mentioned, that was when we switched to high quality masks, high quality respirators. I think the reason we didn't do that before, we didn't translate so well before, is just because there was a hesitation about making people do something that they might be uncomfortable with. Masking was already becoming a little bit sensitive. And so, it just didn't feel comfortable to do that. But once we had a case in school, then in discussing it, we decided to uphold the objective number 1 to keep everybody healthy. Then we would go ahead and do it. By late fall, early winter, kids were vaccinated. Maureen is saying as well that for people who had trouble getting high quality masks, school was able to give them out through the AIMS grant as well. Yeah. Any more? Anything else? Okay. Kids were vaccinated October, November, December. And in our school, almost 87% of students received that first series, the 2-dose series. Before, of course, it has changed to more than a 2-dose series. So we had a really high vaccination rate in school. And we had planned to reduce mitigation soon thereafter, and then Omicron hit, which is where another really big translational push happened. Because like I mentioned, there was a lot of questions around testing at that time. So we were asking people until the information became more clear about the effectiveness of tests in Omicron, we were asking people to do some more serial testing early in the wave. There was a reduced time from exposure to someone becoming symptomatic after exposure in the Omicron wave, in part due to the variant itself, in part due to the baseline antibodies that people had, and the vaccine protection people had. So we would ask people to test sooner or test earlier and not test quite as long. For a brief period of time, because we were just worried about how infectious Omicron might be, we asked siblings, if someone was positive in the household, we would ask a sibling to stay home, but we relaxed that pretty quickly. But those were some of the tweaks that we made to try and adapt to the science, the science of Omicron as it hit, and then as we learned more about it. Okay. The biggest, some of the hardest times, I think, and one of the biggest turning points amongst the school community was when the CDC changed their guidelines about a year ago, last March, from the community level, or to the community level, from the community transmission level. And I love this figure because, on one day early in March, on the right-hand side, half the country was red, and feeling like there was so much COVID, it was still scary. We shouldn't go outside without a mask. And then literally with a flick of a return on a keyboard, the country became green. And when the country became green, and maybe even before that, most of the other institutions in the area, including Penn State, other school districts, were just done, and really scaled back their mitigation. And we looked at this figure and all the changes, and we weren't so convinced that that is what we should be doing, because there's still a lot of unknown questions about long COVID. If people are out of school, then they're out of school for a period of time. It means having to find substitutes, parents having to find childcare, et cetera. So, I'll talk about in the next few slides, we did not change our mitigation to match the CDC last March. We drafted a letter, the pandemic advisory group that, again, was us public health professionals, administration, and a teacher, and tried to explain, using some of the Quaker values about community and stewardship, about why we were going to finish the year with the current mitigation that we had. But again, this really felt like a big turning point, where, because the CDC said a number of things could change about masking, about how long you needed to be in quarantine, that it's really hard to go against the CDC, even with a lot of scientific evidence, like the next slide. So we held on to two-way masking, and we still are for another week or another 3 days at school. But we held on to two-way masking because of this slide. And using the slide because we wanted to again, go back to our objectives of upholding the health and safety of people, students and faculty, when they're at school. So this slide is looking at, on the left-hand side, if the source is wearing. So what kind of mask someone who might have COVID and is infectious is wearing. And then on the top, along the top, the columns going down, is what the receiver might be wearing. So, thanks. So if the source person, someone who has COVID, is wearing nothing, and the receiver is wearing nothing, it's estimated. Some people might take issue with the specific minutes on this chart, and I agree, this is not perfect. But if you zoom back and think about the relative times, if you're frustrated by it, you can think about it that way. So let's just say it's about 15 minutes. It's probably a lot quicker now with the more infectious variants. But if both the source and the receiver are wearing nothing, within 15 minutes, you're very likely to pick up COVID. But if the receiver is wearing a fit-tested or a non-fit tested N95, which is what we'd be wearing, and the source is wearing a non-fit tested N95, you have protection in theory up to 6.25 hours. So nothing compared to wearing an N95 is on the realm of 5 to 6 times more protection. Yeah, and so this supported two-way masking at school, and is the reason why we translated this into, we are going to continue to mask at school. But again, that's not what the CDC said, which made it a little bit of a sticking point for some people. But this is the data that we use to make that decision. Next slide. Another sticky decision around that time was the CDC said, and understandably, because during especially the early months of the Omicron wave, so many people in public jobs, in hospitals and security were getting sick with COVID, that they needed people to be back in the workforce sooner than they, the 10-day quarantine or the 7-day plus a test quarantine, isolation. So at school, we really thought, what is the best way to proceed? Do we want to follow the new CDC guidelines that reduce it to 5 days and then masking with a high quality mask after 5 days? Or do we want to keep people out of school while they're potentially infectious? So the CDC made that change on the one hand, and then literally within days or weeks, they published this in an MMWR showing how many people continue to test positive on a rapid test days 5 through 9. And over a significant amount of people are continuing to test positive after day 5. And we know from other data that there's a strong correlation between testing positive on a rapid test and infectiousness. And now there's even better data that shows correlations between testing positive on a rapid test, culturing the virus, so it continues to grow, and therefore infectiousness. So there's clear data about infectiousness days 5 to 9 until someone tests negative. And we decided again to translate this into the policy of, if you continue to test positive, then you can't come to school. Again, another sticking point that when the CDC changed, just made it a more complicated environment, as if COVID wasn't hard enough. Okay, so this COVID year, one of the things that happened last year throughout the year and now is in force this year is a vaccine requirement. So any newly enrolled family has to be vaccinated and is supposed to be vaccinated up to the current CDC recommendations, which we knew were going to evolve. And so we had written the policy to include future vaccinations. So of course we didn't know that the bivalent would exist by now, but we did know that probably boosters would continue to be recommended. So any newly enrolled family has to be up to date. For existing families, for those who chose not to vaccinate, we've worked with them to be able to stay at school and have made some modifications for those families. We did reduce some mitigation to start the school year, probably too many for some and probably not enough for others. And there is a plan to scale back starting after spring break. A number of things will change. Masks will be optional. More and more integration between classrooms at school, which has already started really and started last year, but is continuing to increase. More and more interaction outside of school with field trips and like buddies at a facility. I'm not sure what it's called, Foxdale Village, right outside of school. So for example, there's like reading buddies between the K-1 classrooms and elderly residents who live at Foxdale Village. So we're definitely an outlier and continuing an outlier in terms of having any mitigation, and are scaling it back to be more in line with what's going on in the rest of the community. Next slide. So as you probably have already inferred, we've had such a strong focus on effective interventions because we are public health minded. And that is where the teachers wanted to be for a long time. That's where, even though we've had different heads of school, that's where most of the heads of school have been. And we've been able to do that in part. I watched Paul Simon's seminar, who spoke last month, and he talked about developing policy for 10 million people in LA County. And he described LA County, which is of course incredibly diverse with different populations, different socioeconomic status, just the incredible heterogeneity in LA County. And we don't face that challenge. We're a small school with diversity, but much less so than LA County. So we've been able to be public health minded. But of course, a lot of that comes with impacts and costs of policies. And at every point along the way, we've tried to think about those. I'm sure we haven't appeased everyone, but there's definitely impacts on learning, on social development, on mental health of children. And I think this cuts both ways because I know that going forward, there's a lot of children who have anxiety about COVID and unmasking. At the same time, there's a lot of children or a lot of parents and teachers might argue that children's mental health is suffering by continuing to mask and maybe, through last year, not this year, having to distance 3 feet at times. Children with special needs, any learning disabilities, speech, hearing, maybe in the younger age groups, learning language development, might have suffered from continuing to mask for a long time. In the first 2 years, there was a feeling amongst the community that the community feel had, the Friend School had kind of lost its way or lost its community feel, and that is such a strong reason why people love the Friend School. So definitely some of that suffered early on, and hopefully now the community feel is back, maybe not to the way it was, but in an adapted way back and only getting better. There's no doubt that a lot of the policies led to teachers feeling exhausted and burnt out. We still have very low turnover, but asking teachers to constantly, last year again, not this year, tell kids to space out more, space out more, space out more. I think at some point, everyone thought, what are we doing? Parent burnout as well. School didn't offer childcare last year. And as a house with 2 working parents, that was exhausting. And I know other families have had to reduce hours because they just couldn't keep up with the demands of having their kids home. And of course, we've talked about, and we haven't always agreed on this, but of course there's social disparities in the school, maybe less extreme than in other school districts. But for example, there were families who, if there was a positive case in the family, one person could completely isolate themselves. They had a separate bathroom, they had a separate, apartment or basement or something, and not everybody has that. And so, so in terms of coming to school, we could allow those kids to come to school isolated from whoever it was that was sick, because they wouldn't potentially introduce the virus, but then it could extend any inequalities, because a child who has that has the ability to come to school, where a child who doesn't have that could have to be out of school for some periods of time. So those are some of the costs and the impacts that we know of. And maybe, I'm sure there's others, in addition to the financial costs of extra childcare, parents having to take off of time from work potentially, school needing to hire subs at times if someone was exposed or sick. On the other hand, a lot of mitigation also isn't expensive. School's been able to provide the high quality masks with the grants. School is able to buy the filtration units. So we've tried to allay the financial cost as much as possible. So this is the last slide before some questions. So I would say that one of the biggest challenges following the science to meet our 3 objectives. In some ways, I think our objectives could have been clearer and maybe more publicized, because when the CDC changed those rules last year, so many people were confused, like, well, is the CDC following the science or are we following the science? And my answer was, well, it depends on what you're trying to do. You can follow science to take you to different places and different objectives. So we believe we're still following the science to meet our objectives, but the CDC objectives changed, and we're no longer focusing on reducing transmission as much as we were. People were getting information and continue to get information, of course, from different sources. So we're more focused on the scientific literature. Other people might be listening to various newscasts, watching various news, reading different things. And I will say that some scientific writers, I think, do a really wonderful job, and some scientific writers do less well at getting the nuance across. So often we're in a role of being educators. I think the risk assessment about COVID in kids has been really misleading and not often very helpful, because we compare COVID, the effects of COVID in kids to the effects of COVID in adults. Whereas I think the better comparison is the effect of COVID in kids to other diseases, possibly at this point, even other vaccine preventable diseases to kids, not to adults. But that's usually not how it's framed, and I wish it were. Also, of course, though, kids don't live in a vacuum, and there's many families at school who have multi-generation households. Parents are grandparents are the primary caregivers. There's also grandparents who have terminal illnesses. So, of course, school is a school of children, but they live in a broader community. So it's not always just about the risk assessment of COVID in children. Penn State was one of the earlier institutions, to my knowledge, that dropped, maybe not compared to other universities, although compared to some for sure, that dropped masking and dropped mitigation efforts. And I think that really changed the psychology of State College. So again, it just made having more public health minded policies a little bit harder to defend. Maureen was able to draw a connection with a group that was analyzing the wastewater in the State College area. And I don't know if you want to talk about some of the challenges of that, or
Yeah, I mean, you know, the research that we had seen come out on wastewater was promising, and we were hoping that if we could see the trends in the wastewater and be connected with those folks who were testing the wastewater, that we could use that as a guide of maybe if we had gone mask optional. You know, I made this connection during Delta, during the, you know, maybe not the peak of the Delta variant, but when it was on the rise. And I thought, you know, if we are going to go masks optional, you know, we could rely on that data to tell us when to increase our mitigation or to decrease it. And unfortunately, the wastewater would the numbers seemed to trend with the tests, so it didn't actually give us a heads up the way that we had hoped it would.
And our very last point is a challenge, I think, we have in understanding population versus personal risk, or effective in intervention, especially in a world where people might just be reading headlines. And I think a really good case in point is the recent Cochrane review about masking, which is I believe is a question of, are mask mandates effective? And the answer is probably not very at all. But if you and I are wearing an N95, is it going to reduce the risk of transmission? If I wear it effectively and you wear it effectively, yes, absolutely. And if in a small school, can we make that a policy, and can we enforce it as best as we can, which is not perfect. I see kids and teachers with slippy masks quite often. But it's a question between population versus individual, or, you know, yeah, I'll just leave it at that. So, so next slide is to take your questions and comments.
Thank you very much. I really appreciated all of that information. You know, I think it's really striking that there was only one case of in-school transmission, because that's certainly not the trend at other institutions. Oh, sorry, wait, 2?
Well, that was in year 2.
Year 2, okay, sorry.
That was in year 2. In year 3, which didn't make it onto a slide, year 3 last year, there were 4 total. That includes that one. There were 4 total cases of in-school transmission.
Thank you.
Yeah.
So if anyone has any questions, you're welcome to put them in the chat, but I will start off. I know we only have 5 minutes, so hopefully this won't be the only question that gets answered. But I was really interested, you know, one of the things that through the CTSI Health Policy Impact that we're really concerned about is, you know, as researchers, how do you increase the policy relevance of your work? And I've heard a lot of really interesting insights of what you had, but one of them that I wanted to spend a little bit more time on was this idea of you know, that your point where you said following the science to meet objectives. And, you know, how do researchers frame their research so that the people who are using it will so that it'll be useful for the people who are using it? So I was wondering if you could say anything or any thoughts about that you might have about that.
That's a really good question. I'm not sure I do. One thing that comes to mind is just thinking about the COVID policies were, especially in the first 2 years, is that there was just so much research in older populations and non-school age children or non-elementary school age children, for some good reasons. But then every time we needed to figure out what to do for school, it was like, well, you know, someone would say, well, is there any research about kids on that? And it's like, no. So we don't know. And we need to infer as wisely as we can. So, yeah.
Another question that I had, and maybe is more specific because I know it was kind of like a big think kind of question, is that there was constantly new studies and new information coming out with new variants, and how did you keep sort of up to date with all of the literature, and do you have any advice for researchers about how they disseminate their information?
Maureen, do you want to answer? Do you want me?
Yeah, I think sadly, or maybe in a good way, I actually joined Twitter with the purpose of being able to keep more up to date on literature and that sort of thing. Of course, I eventually settled on a few epidemiologists who I really began to trust, and I really appreciated the clarity that they could explain things with, and at times would amalgamate studies so that and translate them in a way that was more easily understood to the layperson. So I would say, yeah, like Mike Osterholm was a big person for me, and Caitlin Jetlina, and these were some, Eric Topol. They were people who some of who I encountered on Twitter, but others who I heard of by word of mouth.
Yeah, it's Twitter can be a good source, but so it sounds like one thing is to try to understand your audience and how policymakers might potentially use the information. Another could be to be active on social media, and not just be active, but also be someone who is trusted, and to increase sort of your the reliability with which you explain things. The last question I had was that, and this is only like a 30-second question, which is, you mentioned a bunch of connections with Penn State. How did you find these experts, or did they find you?
In the case of Bill Banfleth, the engineer who worked with us on indoor air quality, it was a little bit of both. I think at some point through a random Google search, his name came up, and then it turned out that I had a personal connection to him. So I harnessed the personal connection. Yeah, and for the wastewater, Maureen, you reached out randomly to them, right?
It was kind of a cold call email, and they responded very, very warmly and quickly, which was very nice.
Great.
Yeah,
We are.
I mean,
Oops, sorry.
We did reach out to others, other people as well at Penn State, at the local hospital, the local school district. Yeah, and everyone was so busy trying to figure it out. I think there could have been a consortium of information sharing, but everyone was just so overwhelmed that didn't happen. But that could have been a really great way to also stay up to date.
Right.
And I would say, as a practitioner, the person who kind of did the case management piece, I was also in touch with people at the district, as well as other school nurses around the country.
Well, thank you very much. We are at time, so I really appreciate you coming and speaking with us today, and thank you all for listening and attending.
Thank you, Charlene.
Thank you.